Good morning, everybody. I'm hopeful that my biological clock catches up with the chronological clock that I'm currently living under very quickly. I'm very delighted to be here today. It was quite an honor to be invited to give this talk. And when it was offered, I had no opportunity other than to say yes, of course. So I changed my title a little bit. It's Exercise Training in People with Multiple Sclerosis, What's Known and What's Next? What is it that we need to do to really advance our field and to better help individuals with MS gain the benefits of exercising? So these are my disclosures, my financial disclosure. I suspect I should make one other disclosure, and I hope this doesn't offend anybody. I did not vote for the current president of the United States. I just have to live with this for 4 years. But these are my financial disclosures. So these are the biases and beliefs that I operate from. And one of my biases is that exercise, and particularly exercise training, which is planned, structured, repetitive movement such as running or swimming or walking or resistance training, is really a behavior that is unlike any other health behavior. It is something that's performed up to 20 times one's basal metabolic rate. It involves the utilization of energetic resources. It's very much an approach and an engaging behavior as opposed to others that oftentimes are withdrawal-related behaviors and performed at rest. Exercise is considered a multi-system integrative stimulus. That is, it activates nearly every physiological system in the human body in a systematic, integrative manner, and that is regulated by the central nervous system, hence the reason why we believe that exercise can ultimately change around the way the brain is working in health and neurological diseases. And I will stick by the statement that I made about 10 years ago. Exercise training is not just medicine. Exercise training may be the best medicine. So let's see why I might say that. So this is the overview of my presentation. I'm going to talk about the benefits of exercise training. I'm going to talk about the safety of exercise training because that's always a concern that I hear is exercise safe for people with multiple sclerosis. We'll talk about prescriptive guidelines. That is, what is the prescription, much like medication, that individuals should utilize to experience the benefits. And then I'll spend time on the future of exercise training in MS. So let's start with the benefits. I want to point out that the application and the study of exercise is not new in MS. Oftentimes we think what we're doing today is cutting edge, is new, we're breaking new territory, and with exercise, this is simply not the case. This is an excerpt from Jock Murray's book, The History of a Disease, Multiple Sclerosis, and this is an excerpt by John Abercrombie in 1838. He's writing here, there was along with it a diminution of muscle power. He was talking about a patient. He could walk a considerable distance, though he did so with a feeling of insecurity and unsteadiness, but he could not in the smallest degree perform such motions as are required for running, leaping, or even very quick walking. And so this seems to demonstrate that this individual had many mobility-related problems, which are hallmarks of multiple sclerosis. This individual was otherwise in good health. Various remedies were employed without benefit. Evacuations and spare diet seemed to be rather hurtful for this individual. This individual continued in this state for which I described for about 2 months when he determined to try the effect of violent exercise. Not a term that I would use, but I don't get to change an excerpt. I don't get to change the story. What is this violent exercise? For this purpose, he walked as hard as he was able, 5 or 6 miles in a warm evening, and returned home much fatigued and considerably heated. Okay? Well, I think if any of us who were not regular exercisers walked for 5 or 6 miles in a warm evening, even those of us who are regular exercisers might come home with a bit of a thermal load and a little bit of fatigue that we might have to manage. Next morning, he had severe pains in the calves of his legs. Again, go walk 5 or 6 miles. I think you might experience the same thing. But his other complaints were much diminished, and a few days disappeared. He has ever since enjoyed very good health. And so I bring this up because this is one of many, many excerpts written in this book, The History of a Disease, Multiple Sclerosis, that articulate the value and the application of exercise in multiple sclerosis. Now, the first randomized controlled trial of exercise training was conducted by Jack Pettijan, who is in the very top there, and Ed Gatmeyer, who's in the lower part of this slide. Jack was a neurologist at the University of Utah in the United States, and Ed Gatmeyer was working on his doctoral degree at the time in physical therapy at the University of Utah. And they were fortunate to lobby the National MS Society in the United States to fund a randomized controlled trial of exercise, and not just a simple exercise bout, but a very, very strenuous and tough exercise program in people with multiple sclerosis. And their exact purpose was to show that exercise didn't make neurological disability worse, but that it actually had no effect on neurological disability, and many other outcomes would improve. They did a randomized controlled trial where they took a large sample of individuals, randomized them into intervention or control. The control was an attention-controlled sham condition where individuals received attention and social contact and engagement. The exercise program was training 3 days per week for 40 minutes at a very high intensity. And they used this beautiful device called a Schwinn Velodyne. And a Schwinn Velodyne is a device where you pedal with your legs, but you're using your arms at the same time. So you have a full body exercise stimulus. And it's something that's used nowadays in what people refer to as cross training is the new stimulus. And this stimulus is not new. This was over 30 years ago that they were applying it in multiple sclerosis. And they did this 3 times a week for 40 minutes, this combined arm-leg ergometry at a moderate to high intensity, and they looked at outcomes. They found that disability was unchanged, whereas in the control condition, it was worsened over this period of time. They did find, very surprisingly, that within the neurological systems assessed by the EDSS, that bowel and bladder function actually improved with exercise training compared to the control condition. Other outcomes, they found improvements in aerobic power, in upper and lower extremity strength. They found significant changes in comorbid conditions, particularly lipoprotein levels. They found improvements in depression and anger. They found fatigue was reduced. They also found improvements in nearly every subscale of the sickness impact profile. And so overall, exercise was quite successful in this very early study that was actually published in the Annals of Neurology. This was a jumping point, so to speak, and I'll show you that here. On the left-hand side, you can see the early 90s. The field stayed very quiet for a period of time. Sometime in about the latter part of 2000, so around 2010, you can see that the field took off. The number of publications involving randomized controlled trials of exercise training in people with multiple sclerosis jumped considerably, and it stays quite elevated today. And I think many of the origins of this are people in this room. Jens, as an example, has been very, very involved in this research. And when I did this search on exercise training in multiple sclerosis and narrowed it down to randomized controlled trials, there were nearly 500 of them, and I'm going to talk about each and every one over the remainder of this talk. A daunting task. But I'm going to do it in a very specific way. Meta-analyses, okay? So the good thing is that this literature has been very well summarized in meta-analysis. And so this is a picture that shows the evidence related to exercise training and different outcomes in people living with multiple sclerosis. We will start with the very top, facing you on the left-hand side, physical fitness. We know that exercise training, if done appropriately, improves aerobic power, and it improves muscle strength and muscle endurance. And we would expect this with exercise training. It's not anything that we shouldn't expect, but many people don't realize how important having high level of aerobic power and muscle strength is to everyday tasks and the things that we want to do to be productive in society. So I don't want us to undervalue fitness as an outcome. When we move down from fitness to fatigue, we can see that the second largest benefit with exercise training involves reductions in symptomatic fatigue in people living with multiple sclerosis. The reduction is actually clinically meaningful, such that you can take individuals who are above a threshold score on fatigue severity scale or other scales, and by the end of the trial, their fatigue level is below that clinical threshold for fatigue severity. Moving from there, we see that exercise training is very effective for managing depressed mood and sadness and loss of pleasure in everyday life tasks. That is, randomized controlled trials are demonstrating, again, a clinically meaningful reduction in symptoms of depression in people with multiple sclerosis. Now, when we start to move down, you can see that the line is getting a little thinner and a little narrower, and it's changing. It doesn't show up here, but it actually is changing in color a little bit. And that's demonstrating that the evidence is starting to get a little weaker. So when we move into mobility, particularly lower body mobility, so walking, such as the timed 25-foot walk, 6-minute walk, timed up and go, or balance, we see that there are improvements with exercise training in these outcomes, but the improvements are a little bit smaller in magnitude. They still tend to cross a threshold of a clinically meaningful improvement, but they become smaller in magnitude. When we get to quality of life, the effect is still there, but it is, again, becoming smaller in magnitude. When we get over to the other side, you can see that we kind of have moved the outcomes to a side where the lines are very small. And something that has really pained me is we can't seem to be able to demonstrate an effect of exercise on cognition. I'm sorry, Iris. We might get there someday, but it doesn't seem like it's working. Upper body mobility doesn't seem like it's changing much. There's not a lot known about exercise and anxiety, but there's not a lot known about treatments for anxiety in general in multiple sclerosis, and it's something that my lab is dedicating a lot of time to right now, because outside of the world with MS, exercise seems to be very powerful for treating anxiety and anxiety disorders. There's a little bit known about pain and a little bit known about participation. The data on exercise and participation is getting stronger. With Ulrich Dahlges, Thomas Edwards published this really nice meta-analysis demonstrating that participation improves with exercise training across studies in multiple sclerosis. So we have a lot of evidence that exercise training does have benefits. That's summarized here in this slide, and I've organized this in the meta-analysis in a very specific manner and on purpose. I think that exercise training is improving aerobic power, it's improving muscle strength. That's translating into improvements in walking performance, reductions in fatigue and depression. Ultimately, that's translating into improvements in health-related quality of life and participation. On the other side here, these are data from systematic reviews, and I've isolated them because we all know that systematic reviews sometimes contain the biases of the authors trying to make a case. Sometimes, can contain some biases in the cases that they're making, but nevertheless, some of the things that have been reported in the literature, exercise training seems to reduce the rate of relapses in people with multiple sclerosis. And it seems that exercise training reduces the rate of relapses by 25% compared to control conditions. I would point out that this is similar in magnitude to the effects that early disease-modifying therapies had on relapse rates in multiple sclerosis. So some people have suggested maybe there's a disease-modifying potential for exercise. There seems to be evidence that exercise is reducing comorbid conditions. And as we all know, comorbid conditions, based on Ruth Ann Marie's work, are very important in disease progression, disease translation from relapsing to progressive disease courses. And maybe this too opens a door for managing disease progression. Our lab is currently looking at vascular dysfunction, arterial health, and the vascular tree within the human body to understand the underlying contributions of exercise to comorbidity. Maybe cognition is improved. There are some data emerging that you can improve MRI metrics, such as connectivity in particular. Maybe some biomarkers. There are some data for BDNF. But maybe looking at other biomarkers, neurofilaments to be precise, might open up some opportunities for us to further understand exercise and disease progression. So moving forward from there, we have evidence on the benefits. Let's move to safety. Two really prominent reviews, one by Lara Paludi that's in the top, that's a systematic review that was published about 12 years ago, and the second by Yvonne Lermont, which is an updated systematic review and meta-analysis, and I'll talk about both. So in this first systematic review of the literature, Lara reported that the rate of adverse events for control conditions was such that about 1.2% of participants in these trials had an adverse event of some nature, whereas the rate of adverse events for exercise training was about 2%. So about 2% of participants in exercise training conditions had adverse events. When you compute a relative risk of adverse events with exercise training compared to controls, it is elevated at 1.67%. That is non-significant, I would point out. So there is an increased rate of adverse events with exercise training in people with multiple sclerosis. If you look at exercise training in the general population, it's actually even higher than this. It's about a relative risk of 2. So this isn't surprising. Anytime you get people to start moving who don't normally move, sometimes accidents and injuries happen. When we look at the types of adverse events that happen, illness is something that happens very often as a reported adverse event, but other things that are being reported with exercise training, low back pain. And low back pain is particularly occurring with resistance training, and it's entirely preventable if we utilize high-quality trained individuals to deliver resistance training interventions. Jens and I were talking last night that oftentimes our therapists go off script. And I think when our therapists go off script and they don't follow our protocols is when these sorts of things are occurring. So these are the data from the meta-analysis. When you look at this forest plot, you can see that there are quite a few randomized controlled trials that have been included in this analysis on adverse events, which is on the left hand as you're facing the screen, serious adverse events, which are things that require medical attention and hospitalization, on the right-hand side. Overall, the relative risk of adverse events for exercise training versus controls is a relative risk of 1.4, so about a 40% increase in the risk. It again is non-significant, meaning it's not different from 0. So it indicates that this point estimate doesn't really indicate a significant risk of adverse events. When we look at serious adverse events, the beauty of this is the relative risk is 1.05. So there is no elevated risk of serious adverse events with exercise training. And so we feel as though we can make the recommendation that exercise is a very, very safe approach for people living with multiple sclerosis. So if exercise is safe, if exercise has benefits, what should we tell patients to do? Fortunately, there are prescriptive guidelines for exercise training in multiple sclerosis. These were developed by Amy Latimer-Chung, who's in the red jacket, and Kathleen Martin-Guinness, who's on the right-hand side. They are Canadian researchers who developed these. One funny little story and anecdote about this, these were actually published as the Canadian guidelines. And you'd think that that wouldn't matter, but we did a qualitative study asking Americans what they thought about these guidelines, and they said, well, these are for Canadians, they're not for us. But the good news is Trump's taking over Canada, so, whatever, right? It'll all be fixed soon. So these guidelines are really based on a systematic review of the evidence. So they really are evidence-based guidelines. And the systematic review was given to a large group of scientists, of clinicians, of people living with MS, And all of these individuals were sequestered in a room, like many guideline activities happen. And we all left the room with PTSD. And the reason for that is because there was arguments and fighting. Your charge was to put forth the evidence behind a guideline, and everybody else was supposed to tear that down. Sounds like a very fun process, doesn't it? But the goal of that was to create a guideline that could withstand criticism. And in the end, we felt like we had a guideline that could withstand criticism and that was uniformly approved. And this is the guideline here. It says that people with multiple sclerosis who have mild to moderate disease, there wasn't enough evidence for people with severe disease, should engage in 2 times aerobic activity and 2 times resistance activity every week. The aerobic activity could be done on the same day as the resistance activity. They didn't have to be separated. But the resistance activity should have 1 day of rest for muscle recuperation in between the 2 sessions. That was the only caveat. The aerobic activity should start with a small amount, 5 to 10 minutes, and gradually build up to 30 minutes of aerobic activity on those 2 days per week. The resistance exercise should start with a very light resistance, 1 set of 5 to 10 repetitions of maybe 5 muscle groups, 2 upper, 1 core, 2 lower, and then build ultimately to 2 sets of 10 to 15 repetitions of 10 different exercises across the human body. How hard? We said moderate intensity for aerobic. For resistance, we told people, choose a resistance that you can do 10 to 15 reps. When you get to the end, you should feel a lot of fatigue and be unable to continue. The modality for the aerobic, we recommended upper body exercise, arm cycling, lower body exercises, walking or leg cycling, or combined upper and lower, an elliptical trainer machine where you're standing and moving the legs simultaneously. For strength training, the recommendation was weight machines, free weights, and cable pulleys. We put this thing called other types of exercise that may bring benefits because the evidence was weak: elastic resistance bands, aquatic exercise. I'm sorry for people who might love aquatic exercise, and calisthenics. These are recent updates of the guidelines. We have the general aerobic and resistance guidelines, and I've underlined some things that have changed. Now we're recommending 3 days per week of aerobic and 3 days per week of resistance exercise. The aerobic, we're suggesting not just treadmill, but actually over ground walking. We're now suggesting that the evidence is strong enough to include aquatic exercise, particularly swimming. On the resistance side, we're now including resistance bands, which are great because people can do this in their own environment. And we've created an advanced aerobic exercise prescription. There are people who've been exercising and have MS long enough to where they've plateaued and they need to do more. And so this added prescription that's advanced is up to 5 days per week, up to 40 minutes of aerobic exercise per session, high intensity, so doing something akin to high intensity interval training, and even bringing in running and road cycling as opportunities. So what does the future of this field look like? Because that's where the excitement really is. So one of the things that we've been bringing to people's attention is this idea of response heterogeneity. And people within my field cringe when I talk about response heterogeneity with exercise, because they oftentimes believe if you give a group of individuals the exact same exercise prescription, they will have the exact same adaptations. And it simply does not work that way. When we look at these individuals, some individuals with same exercise stimulus will get worse, and it's about 25% of individuals. About 25% of individuals will not change at all, and about 50% of individuals will get better. And so the question becomes, what's happening with those 50% of individuals who are getting worse or not getting better? And this is the idea of response heterogeneity. We're trying to understand biomarkers of lack of adaptation or adaptation, and then create precision medicine frameworks such that we can give the right exercise prescription to the right individual to get the adaptations that we need. And this is seen oftentimes in the treatment of cancer, where the top shows that we give all cancer patients the same therapeutic, and they show differential responses. The bottom shows that if we can identify a biomarker and we give individuals a treatment and a therapy based on that biomarker, then we can help all individuals benefit. And this is one of the things that we're trying to focus on right now. The other thing is, when you look at the majority of the literature on exercise training in people with MS, it is heavily biased towards young and middle-aged individuals and individuals who are Caucasian or white. But we know that the face of MS is changing profoundly right now. That is, we have a general aging of the MS population. We have a general change in the racial and ethnic demography of multiple sclerosis. And we need to begin to identify programs that are appropriate for these other individuals who are living with MS, who need to become a focus of our clinical trials, because they deserve high-quality evidence as well. We need to understand more about adherence and compliance with our regimens, particularly the trainers who are delivering these, because there's a lot of variation in what people are doing. And that variation likely explains differences in outcomes, and we need to understand this so we can try to create more standardized protocols to maximize the benefits of exercise training. We need to think a lot more about our biology of the responses to exercise and how to utilize this to create the right exercise training regimens for individuals with multiple sclerosis. And this is a paper that was published by my colleague Marcus Bamman, where he argues that every exercise study should start by looking at a single bout of the exercise stimulus and characterizing very precisely what is happening in the human body. And by utilizing that and understanding what is happening in the human body, that will guide us as we move forward into our chronic training regimens. And this is a model that he's put forth for doing this. Mechanisms. We do not have a good grasp right now for why exercise training has the benefits that it has. And we need to bring together this experimental medicine model that will help us more precisely understand the mechanisms for why different modalities of exercise, whether it's resistance training, aerobic training, lifestyle, physical activity, result in outcomes such as walking, cognition, fatigue, and depression. And where this is occurring, is it a brain central nervous system adaptation? Is it an adaptation within the vascular physiology? Is it an adaptation within psychological systems? Where does this occur so that we can better understand this? We need to understand combined therapies. I won't go into this trial called COG-X, but COG-X was a multi-country experimental trial looking at exercise alone or with cognitive rehab for progressive multiple sclerosis. The trial didn't work. And the question becomes, why? And it really becomes a why because we were utilizing two therapies simultaneously, and we thought that that would have added benefit. So summary and conclusions, because Iris is about to tell me that we're on Swiss time, not American time. In this green box here, it's pretty clear that exercise training, lifestyle, physical activity have profound benefits in people with multiple sclerosis. We have a prescription to achieve these benefits, and we know if you follow that prescription, it's safe for people with multiple sclerosis to exercise. But what we need to know is more about how to identify who benefits and under what conditions they benefit the most, and that's precision. We need to understand inclusion, that is, how to utilize the right program, and does it need to be put in place in the right way for the right individual based on race, ethnicity, age, maybe even gender and gender identity. We need to understand how to optimize and maximize our protocols. We need to understand clearly the mechanisms, and there are many people in this room who can offer more information about whether or not there really is evidence for exercise and MS pathogenesis. That's why there's a question mark there. Or body structures such as axonal and neuronal loss. And lastly, Number 6, we need to think about how exercise works with other therapies. Exercise and diet are very complementary, but they're not being used that way in the scientific field. And with that, I will say thank you.